foregut, the midgut. So still at this stage also you can see this midgut, it will be in communication with the primitive yolk sac. And the part which is more distal, it will be called as hindgut. So at very early stage, around 3 weeks, when you will see this tube, you will find this tube is closed from both the sides. Okay, this is one side where we have the oral membrane or buccal membrane, okay, or buccopharyngeal membrane. And then this is the lower part. Okay, so this is quite obvious that here we will have the anal canal. So this is also closed by the cloacal membrane. Okay, so what are the two membranes? So more proximally we have the oral or buccal membrane. Distally we will have the cloacal membrane. And in between them we have these three parts. Okay, so the foregut which will be incorporated into head fold, the hindgut which will be incorporated into tail fold, and the midgut which is in connection with the yolk sac. So again, I will show you some of the part of this developing embryo. So here you can see that this is the notochord, the developing notochord, which is going to form the central nervous system. So this is going to be brain and spinal cord. This area, it is related with the foregut. Okay, so this is the cardiogenic area, which is in future going to form the heart. Again, here we can see the membranes, and this is our tube. So now this whole GIT, okay, its mucosa, it will be developed from the endodermal lining. Okay, so now we know three germ layer: endoderm, ectoderm, and mesoderm. So the mucosal lining, we know the mucosa, you have studied the histology. So in that, the mucosal lining will be formed by the endoderm. Except there are some places this will see like the oral mucosa and the lowermost part of the anal canal where we have ectoderm. Then we have the muscular layer and connective tissue which will be formed by the secondary mesoderm, splanchnic secondary mesoderm. In whole GIT, there is something which is there is something which you will find that it is a tube. Okay, so now just imagine there is nothing, just a tube from oral membrane to the cloacal membrane. So when this tube will develop, first of all, this tube is a hollow tube. Okay, then slowly what will happen, this endoderm will proliferate and the lumen will be closed completely. There will be obliteration of the lumen. Then again at week 8, this lumen will have recanalization with the process of cell degeneration. Okay, these are the three stages at week 5, 6, and 8. First, there is proliferation of the cells, endodermal cells. Second, obliteration of lumen. And the third, recanalization due to cell degeneration. Okay, because now you know some of the congenital anomalies which is known to you, like stenosis, like atresia. What is atresia? So atresia means there is no recanalization at all. Okay, there is no lumen in any of the part of the GIT. Or there could be stenosis. What is stenosis? Stenosis is incomplete recanalization. The lumen will be narrow. And sometimes the recanalization, it will happen in some haphazard pattern, will be incomplete, which may lead to duplication of the lumen. So we will see slowly. one by one. So this is our primitive gut, which has foregut, midgut, and hindgut. And always remember, so what I am telling, along with this, many other changes are also happening. Like here, we will have the presence of the primitive dorsal aorta. This will be the site, and this will send the branches to the developing foregut, developing midgut, and hindgut. So all these small branches will disappear. Only the main functional or principal arteries will be present, which are the branches from the abdominal aorta. So for foregut, we have the celiac artery. For midgut, we have superior mesenteric artery. For hindgut, we have inferior mesenteric artery. So this I believe all of us know. Now again, we have the same picture which is showing the development of the gut tube. So here, what is the development? Here you can find that the midgut, which was having a very wide connection with the yolk sac, now it has become narrow. Okay. Again, here you can see this with this red color. This is the developing aorta. Okay, which has sent is three arteries, three main branches to this gut tube. Again, you can find there's a developing heart, and here you can find something is happening in the hindgut also, which is this is the allantois, attachment of the allantois, and there are some structures present over the hindgut. Again, if you come, this is the later stage, around you can say 5 weeks, where you can find that the gut tube has resumed sub shape. Okay, here you can see this is the fusiform dilatation. Okay, and here you can see these again, the midgut has completely become tubular. Okay, here you can see it was not tubular, it was just narrowed. But here it has become tubular, and it has also its artery together, which is superior mesenteric artery. Okay, so now we will see properly what are the derivatives of foregut. So till now we know that it is going to form the pharynx, okay, like oral cavity, pharynx, tongue, tonsils, salivary gland. As additional knowledge is the upper respiratory tract. Okay, the upper respiratory tract also develops from the foregut. Then we have the lower respiratory tract. Okay, so if we see carefully, we will find that from the foregut there is a development of respiratory diverticulum, this blue color. Okay, this respiratory diverticulum, which is going to form the lower respiratory tract. Then we have the esophagus, obviously, stomach, duodenum. So in duodenum, we have the twist that its upper part, proximal to opening of the bile duct, will develop from foregut. Then liver, biliary apparatus, and pancreas. So this is something more advanced stage in which you can nicely see the different shapes of the organ has been developed. Like this is the liver. Now you can see this midgut tube, which has become more tubular with some rotation. Okay, and here you can see this is the developing respiratory bud, which is going to give rise trachea and lungs. So all these structures will be supplied by the celiac artery, celiac trunk, except we have the pharynx, respiratory tract, and we know the esophageal, it has the additional blood supply also from the esophageal arteries. So when you see the development of esophagus, so this is around 4 weeks, we will find that the cranial part of the foregut, okay, which is just caudal to primitive pharynx, it will form the esophagus. Okay, so again, just take a look at this. This is the respiratory diverticulum. So here, this area, okay, which is going to give us the esophagus. So what is very here, something which is uh, very important to know is that there are two tubes which are developing together. Okay, like here we can see this is the first stage. Here you can see that there are two tubes which are developing together. Okay, and in between this tube we have the one septum called as tracheoesophageal septum, which will develop. Okay, and at the final stage these two tubes will be totally separated in the form of esophagus and laryngotracheal tube. Okay. So again, when we will see here, this one tube will be here, one tube will be here, which will be separated by the tracheoesophageal septum. Okay, again we can see this is the respiratory diverticulum. So this will be trachea. Okay, and here we will have the esophagus and pharynx. So at this stage you will find both the tubes are totally separated. So when we will find that the both the trachea and esophagus will develop in same size. But slowly what will happen? The heart will descend down. Okay, here the heart will descend down, and the additional growth of esophagus will make it more lengthy, and it will descend downwards towards the diaphragm. Okay, again here we can see. Okay, these are the two tubes which are totally separated by the tracheoesophageal septum. So as already I have told you that there will be a hollow gut tube which has become completely blocked by the endodermal proliferation. And again, there is recanalization. And after this recanalization, our gut tube will receive its proper epithelial lining. Okay, so this is one of the very important stage in development of tube, gut tube. What about the muscles of the esophagus? So in the muscles of the esophagus, we already know there are two types of the muscles, striated and smooth. So striated muscles in the upper part, they will develop from mesoderm of fourth and fifth pharyngeal arches. So if you have studied the development of head, neck, face, so you know there are the six arches. So in this fourth and fifth pharyngeal arches will give rise to the striated muscles of esophagus. And in the lower part, these muscles will develop from the splanchnic mesoderm. So as we have this studied already, recanalization, if it will not happen, what will happen? There will be atresia. Okay. And there will be deviation of tracheoesophageal septum. So here we can see there are many stages. Okay, here we will see that there is no connection with the upper and lower part of the esophagus. And the finally the trachea is making a connection with the esophagus. It is called as tracheoesophageal fistula. Tracheoesophageal fistula. And generally it will not be seen unless and until the baby or the infant which is born prematurely, okay, which has not completed the full term. Okay, and in that condition the fetus will not be able to swallow the amniotic fluid, and we can diagnose it in the pregnant female by the polyhydramnios. If they have polyhydramnios, so you can think or consider the tracheoesophageal fistula or esophageal atresia as one of your diagnoses. Okay, so there are different stages for the tracheoesophageal fistula. The another thing we know, if there is incomplete recanalization, it may lead to the Stenosis means the lumen will be present, but it will be narrow. Okay, and there will also be failure of development of blood vessels. Okay, in that condition, there will be narrowing of lumen of esophagus. The short esophagus, as we know, once the uh, the septum is developed completely, the two tubes, the trachea and esophagus, they will grow independently, and esophagus will grow more than the trachea, and it will descend towards the diaphragm. So, in some condition, when there is failure of elongation of esophagus, what will happen? Esophagus will be very short. Okay, in that condition, the stomach may be displaced superior because the short esophagus will pull the stomach upwards towards the diaphragm. Okay, and that will be through the esophageal hiatus. Through this hiatus, stomach will try to go up. There is one more anomaly, okay, which is not related to the stenosis and atresia. It is bigger. It is not narrow. Okay, it is bigger. It is called as mega esophagus. Okay, in this, the esophagus will be mostly the lower part, it will be dilated. Why it will be dilated? Because there will be absence of the ganglion in that area. Aganglionic area. Aganglionic means absence of the ganglion or neural cells, okay, which will make it dilated. If there is no neuron, there will be no muscular control. So as soon as the food will go there, that part become dilated. Then next we have the stomach. Okay, so stomach around 4 week, what will happen? The distal part of the foregut, it will start developing. Okay, it will develop as the fusiform swelling. Can you see here? This is a fusiform swelling. So this is the fusiform swelling. Okay, so from the tube, it will become fusiform. And just imagine, okay, now we know what is the normal position, where is the greater curvature, where is the lesser curvature, right? We know it all. But when it is in embryonic stage, it is different. Okay, in the embryonic stage, we will find that there are two borders, dorsal border and ventral border. So just imagine, where you know already where is the dorsal surface, dorsal part of the embryo, ventral part of the embryo. Okay, so the dorsal part will grow much faster than the ventral part. Okay, so this part obviously which will grow more, this one. This is the dorsal part which is growing more. So this will become greater curvature, and the ventral part will become the lesser curvature. At this stage, you can imagine that this is the ventral border which will give attachment to the ventral mesogastrium. This is the dorsal part or dorsal border which will give attachment to the dorsal mesogastrium. So this ventral mesogastrium will be attached to the anterior abdominal wall. The dorsal will be attached to the posterior abdominal wall. Okay, so again we can see this is the developing stomach. Okay, so this will be the ventral mesogastrium. Okay, this will be the dorsal mesogastrium. In the ventral mesogastrium, you will find that there is a small structure which is developing, that is the liver. Okay, but suddenly at fifth weeks, it will start growing much faster. And what is developing in the dorsal mesogastrium? So in the dorsal mesogastrium, we will find there is developing spleen and kidney. Okay, and this will be attached to the posterior abdomen. So here nicely you can see that whole gut tube has the mesogastrium with the pink color. Anteriorly ventral, posteriorly it will be dorsal. So slowly, with rotation in some of the organs or some of the gut tube, this mesogastrium or mesentery disappears. Okay, if it is remaining, it will be in form of some ligament, some omentum, we will see. So now what is more important here? Now we know the stomach is fusiform. It has anterior border, which is the ventral border, posterior border, which is the dorsal border. Okay. So if you put your hand and just try to see anterior and posterior border, you will see that there are two surfaces. Okay. The right surface and left surface. Okay. Now you want the stomach should rotate in such a manner that it should get its normal position. Okay, like the greater curvature on the left side, lesser curvature on the right side. So this will take rotation in 90 degrees in clockwise manner. Okay, means to the right side. And this rotation will happen in both the axes, longitudinal and anteroposterior. Because now this is just a fusiform tube. So as soon as it will grow into greater and lesser curvature, it needs to be rotated to its exact position. So here you can see, right? This is the ventral and this is the dorsal view. Okay, so this is the right surface. This is the right surface. This is the left surface. And here you can see on the right side we have right vagus, left side we have left vagus. Okay, so when you have studied the stomach, I believe you have seen that it's related to its surfaces are related to the vagus nerve. So what will happen? Now there is a rotation. Just you rotate this. What will happen? It will be sleeping like this. Okay. So in that condition, what will happen? Your, this is the left side. Okay. So this will become left and this will become right. Okay. And this surface will be the anterior surface and this surface will be the posterior surface. Okay. Previously the surfaces were right and left. After the rotation, the surfaces will become anterior and posterior. Then what will happen after this rotation? Okay, so as I told you, the surfaces, the right surface will become the ventral surface, the right surface will become dorsal surface, left will become ventral surface. Okay, the border also move, so the ventral border will move to the right side and dorsal border will move to the left side. Okay, so the same way there will be changing or there will be just not changing the position. You can say after the rotation, left vagus will supply the anterior wall, the right vagus will supply the posterior wall. And what will happen to the dorsal mesogastrium? So it will form the lesser sac of the peritoneum. How? We will see now here. Okay, so here we can see that this is the ventral mesogastrium and this will be dorsal mesogastrium. So now in the ventral mesogastrium, the presence of the liver will divide into the lesser omentum, this one, and falciform ligament, which is between the liver and anterior abdominal wall. Okay, in the lesser omentum, you will find the ligament which is hepatogastric and hepatoduodenal. So with this longitudinal rotation, there is one more rotation which is happening over the antero-posterior axis. Okay, why this rotation is important? To bring the stomach to its transverse position. Okay, if you remember, if we have seen the many models, many pictures, that stomach is lying transversely. Okay, but when we are talking, we are saying that the stomach, it is in median plane. Okay, so this is the antero-posterior rotation. Okay, so in this, what will happen? The cranial end. Okay, this is the cranial end and this is the lower or caudal end. So cranial end will move to the left side and slightly inferiorly. And caudal end will become right and superiorly. Okay, something little opposite. Cranial will go little left and inferiorly. Caudal will move to the right and superiorly. Okay, so at this stage, you will find that the long axis of the stomach is now transversely. And why this is happening? This is happening because of the growth of the other organs like liver. Behind we have the spleen and kidneys. So what happened to the dorsal-mesogastrium? Will it disappear? No, it will not disappear. There will be the development of spleen and kidney. So it will form the gastrosplenic ligament, okay, which is also called as gastrorenal ligament, which is between the stomach and spleen. There will be another division, this area, which is called as linorenal or splenorenal ligament. This one. Okay, and this is the greater omentum, okay, which will be attached to the greater curvature. So if we ask you what are the derivatives of the dorsal mesogastrium, so it is easy. Dorsally or posteriorly, we have spleen and kidney. So there will be ligament will be attached between these organs. So again, this is the transverse section where we can see this is the developing stomach. This is the developing liver. Okay. So this is around 5 weeks. Okay. Then you can see that there will be rotation. Okay. So what is happening with the rotation? With the rotation, you will find that there is the additional structures which are coming and which making the mesogastrium in different shapes. Okay, so let's see about this one. Okay, let's see about the ventral. So ventral, you will find that it has developed the ligament between the stomach and liver, and here between the liver and anterior abdominal wall. Okay, and even the cavities of the lesser and greater sac, it is moving in different direction. Again, here you can see this is the falciform ligament. This is the lesser omentum. Okay. This is gastrosplenic ligament. This is the linorenal ligament. Okay. Here we want to show you about the, along with the rotation, how the ventral and dorso-mesogastrium develops into different ligaments. Okay. So again, you can see here the stomach is almost developed to its normal position. Okay. After rotation. So this is the lesser omentum here you can see. And this is the lesser sac. Have you studied the lesser sac? What is the position of the lesser sac? How you can describe?
We take that it's between the pancreas and the stomach.
Between the pancreas and the stomach?
Yeah, I think something like it.
Okay, somewhat. Okay. Okay, so this is the lesser sac. Okay, which is here behind the liver. Okay, behind the liver and between the stomach. So again, you can see these are the same pictures to make it more clear. So these ligaments again, you can see, I will not repeat again, but here you can see this is the lesser sac. Okay, this is the lesser sac which is behind the liver. Okay, which is behind the liver and stomach here, this area. Okay, this area. So what will happen in the stomach? So in the anomalies of the stomach, first thing which is somewhat like not very common, I will say, but it is common. This is called as congenital infantile hypertrophic pyloric stenosis, CHPS. You will see, you will call CHPS. In that, what will happen? That there will be hypertrophy or thickening of the pyloric sphincter. Okay, circular muscles will be hypertrophied. Why? This is genetic factor. We don't know exactly the reason, but you can imagine if these muscles are hypertrophied, this area will be stenosis. There will be stenosis. When the baby will born, he will have complaint of vomiting. Why? Because the stomach will be full and the food will not be able to enter to the small intestine. So the patient or the baby will present with the persistent vomiting. Then we have other causes in which we already know if the esophagus will not elongate or will not develop to its normal size, what will happen? It will pull the stomach to the thoracic cavity, okay, through the diaphragmatic opening. So stomach will be displaced superiorly through the esophageal hiatus. Like this, there are many stages. This is also abnormality in which the stomach, or you can say this foregut tube, will not develop in fusiform shape. Okay, in between the two dilatation, there will be middle constriction, which is called as hourglass stomach. Then we have the transposition of the stomach to the right side. So as we know, the rotation, if the rotation will happen exactly opposite in anti-clockwise direction, what will happen? The lesser curvature will go to the left side and greater will go to the right side. Okay, so the same will happen with the vagus. Left vagus will supply the posterior and right vagus will be anteriorly. This rotation will happen with not only with the stomach, all the organs will be rotated in the opposite direction. Okay, all the organs will be rotated in the opposite direction. This is called as situs invertus. Okay, this is called as situs invertus, means all the organs, because the rotation is not only happening for the stomach, all the organs are rotating to get its normal position. Okay, so gastric atresia, we can have the complete gastric atresia. Okay, there is no connection at all. There could be a membranous or there could be luminal atresia. Means lumen is there but not completely developed. Now we know about the duodenum. So it's like common to ask what is the what is the arterial supply of the duodenum. So obviously you will say that the part which is above the opening of the common bile duct or origin of the common bile duct, it will be from the foregut. Okay, the part, or you can say the half of the second part of the duodenum, it will develop from the midgut. Okay, and accordingly, it has the two blood supply from the two different arteries. So where is our duodenum? So this is our duodenum, so which will develop in the C shape, which in which it will project ventrally. Okay, so you can see this is the convex part, which is ventrally. First of all, obviously, it has attachment of the peritoneum. Okay, so it will be attached anteriorly by the ventral mesoduodenum, posteriorly by the dorsal mesoduodenum. Okay, so here we have the ventral mesoduodenum, and here we will have the dorsal mesoduodenum. Finally, what will happen? You will find that the as soon as the stomach will rotate, obviously the duodenum also rotate to the right side, and its dorsal mesoduodenum, this one, it will fuse to the posterior abdominal wall and disappear. Okay, and ventral mesoduodenum also some part of it also will disappear. Okay, so here you can see this is the dorsal mesoduodenum, which has fused like this. This is the fused part where you can see, and now here you can see this is the duodenum after the rotation. Okay, so this is the developing pancreas. So we know that the head of the pancreas, it lies in the C-shaped duodenum. So now it's easy to explain the blood supply of the duodenum on embryological basis. I believe, is it? What are the two arteries, different arteries supplying to the duodenum? Yes, are you with
Celiac
me?
artery and superior mesenteric artery.
Very good. Celiac and superior mesenteric artery. So same thing in the duodenum can happen is the atresia due to failure of recanalization. Okay, it involves second and third part in which you can see, okay, you can see different stages. Okay, so you can see the lumen is completely occluded by the epithelium cells. Okay, and here there will be polyhydramnios, which will prevent the normal absorption of the amniotic fluid. So now if you remember, we have seen the polyhydramnios in tracheoesophageal fistula also. Okay, so there are conditions when there is block in any part of the GIT. Okay, this we are talking about embryonic life. So the condition will happen known as polyhydramnios because the fetus will not absorb the amniotic fluid. So mother will have more amniotic fluid called as poly. Poly means more. Polyhydramnios. Okay, so this is the incomplete recanalization which leads to duodenal atresia, and generally it will involve the lower part of duodenum. Okay, so here we have now the midgut. What are the parts developing from the midgut? Yes, duodenum, distal to the opening of the bile duct. Then we have the jejunum, ileum, cecum, appendix, the ascending colon, and the half right two-third of the transverse colon. We have the superior mesenteric artery. So the midgut will elongate. So this is now we are talking about the midgut. We have seen previously the midgut was the wide opening, okay, into the yolk sac. Slowly it became narrow, and finally it will happen. It will form a tube, and this tube is of U shape. Okay, this is convex anteriorly. Can you see this is convex anteriorly and concave posteriorly? This convex part, it is connected again to the yolk sac by this duct, which is called as vitelline duct. Okay, and this is the posterior part. So in the posterior part, you can see that there is a superior mesenteric artery. Okay, and posteriorly it is attached to the posterior abdominal wall by the dorsal mesentery. Okay, now we see it has two limbs, the cranial or upper limb, the caudal or lower limb. So this cranial limb is going to form the lower part of duodenum, jejunum, and half part, or you can say the main part of ileum. Most of the part, okay, but here the lower part or caudal part, it will form the ileum, cecum, appendix, ascending colon, and right two-third of transverse. So how you can remember? Can you see this is the caudal limb? Here there is a development of some swelling, okay, which is called as cecal swelling. Okay, which is called as cecal swelling. You can see here also there is a cecal swelling, and this is the superior mesenteric artery, and there will be some rotation because if you remember, if you have studied the relations of the duodenum, the colon, the superior mesenteric artery, the pancreas, you will find something which is which has been rotated. Okay, why the transverse colon has come in front? The duodenum has gone back. Where is the superior mesenteric artery? Why it is there in between? Okay, it is because of its rotation. So at fifth week, what will happen? Okay, now it's clear there is upper limb, caudal, and cranial limb. Okay, and it is attached to the vitelline duct. So at fifth week, what will happen? In the caudal limb, there is the appearance of the cecal swelling. Okay, so this part which is proximal here, it will form the ileum. Okay, and the part which is distal, this one, it will form the ascending and transverse colon. So what will happen now? We are at the fifth week. Okay, so at the fifth week, the baby is hardly like this. The fetus is hardly like this, where there is no pelvic cavity. Even the abdominal cavity is very small. Okay, and the liver and kidneys are larger in size. So this gut tube is also enlarging or lengthening by its size. So what will happen? At this stage, the loops of the intestine, it will enter into the extra embryonic coelom, into the umbilical cord here. Okay, it is called as physiological hernia. We know what is hernia. Yes, hernia. Okay, it is abnormal protrusion. So here it is physiological because it is normal. So normally what will happen when the gut tube, the midgut will increase in its length. There is no space because there is no pelvic cavity, abdomen is very small. So this developing tube will come out, okay, will come out and see here you can see these are the intestinal loops which are coming out through the umbilical cord. So what will happen between 10 to 12 week? Okay, so that 5 weeks the hernia has happened. Okay, it will be there for 4 to 5 weeks, but at 10 weeks, as soon as the pelvic cavity will appear, as soon as the abdominal cavity become little larger, the liver and kidney will become smaller. So obviously the gut, the mid gut which has gone the into the umbilical cord has to come inside. So this is called as reduction of the hernia. Okay, what is this? Reduction of the hernia. So at first, the upper part of the duodenum, what will come first? The upper part of the duodenum will come and it will lie on the left side. Okay, then the remaining part will come, which will be on the right side. And because we know there is development of the sickle swelling. So sickle swelling as it will be larger, so it will be the last part which will re-enter into the abdomen. Okay, so when it will re-enter, in the next slide, I can show you, yes. So this is the swelling. Okay, so this is the part which has, okay, so now this is in the umbilical cord, you can see here. Okay, now all the parts will go, only the cecal swelling will be remaining. So when this is the developing liver, so when it will go inside, first it will go just below the liver, okay, in the upper part. So here you can see, so first it will go in the right upper quadrant, okay, just below the liver. Then slowly it will descend into the right iliac fossa, forming the right colic flexure and ascending colon. So again here we can see. Now what happened that our jejunum, ileum, they are in so much of rotation. Okay, and why the transverse colon has gone up, why the descending colon, ascending colon had something. Why they are not like in one place together? Okay, so because there is something which is called as rotation of midgut loop. Okay, and it is not only rotation of 90 degrees, it is the rotation three times, 270-degree rotation anti-clockwise or to the right side. Okay, so the first 90 degree it will occur during the herniation. What will happen? So the cranial limb will move to the right. Okay, so this blue is above cranial end, so it has become right, and the caudal limb yellow, it has become left. Okay, so this one we are talking about, this cranial limb and caudal, which was above and below. Now it will become right and left. The second 90 degree will occur during the reduction of the hernia. Okay, around 10 weeks. When there is a reduction of the hernia, so what will happen? The left part, okay, means the previously it was caudal limb, it will move up, okay, and become in front of the cranial. So this will be the future small intestine. Okay. The next, we have third 90 degrees. So when there is complete reduction will happen. Everything is inside, means you can say after 10th weeks. The cecum and appendix will move to the right side. In its normal position, the coils of small intestine will move to the left side to receive its normal position. Okay, so previously the cecum and appendix will be just below the liver, subhepatic. But slowly, as all the organs develop, it will descend downwards to receive its normal adult position. Transverse colon, with this rotation, it will come in front of the duodenum. Okay, and the superior mesenteric artery will be above the duodenum. Okay, so this is the our normal position. So inshallah, in practical, we will again try to see how this rotation happens. So we know the cecum, how it will develop. There will be appearance of the cecal swelling. Okay, and this cecal swelling will, its upper part will become the cecum, and the lower part, this one, it will become little narrow or rudimentary, which will form the appendix. So what is the position of the appendix in response to the cecum? Okay, its position will be posterior medial. Okay, it will be posterior medial. So this is the exact position after the rotation. So here you can see this is the all the intestine have entered or have been deducted to its normal position. Okay, this is the umbilical cord, it is free. Okay, so what will happen if the physiological hernia, which has happened at the fifth week, it should be reduction or it should disappear by the 10th week, but it has not been. So this condition, it is called as the omphalocele. Okay, congenital omphalocele. Okay, so there is failure of reduction of physiological hernia in which the intestinal loops will be present into the umbilical cord. Okay, it may be very small or just covering or very big, and this area it will be covered with the amniotic membrane because this is congenital. Okay, there is another condition called as congenital umbilical hernia, like this is, I think this is the common, maybe you will get chance to see in any baby in the clinic. Okay, but this is not related with the physiological hernia. There will be defect in the muscles of the anterior abdominal wall, here linea alba. Okay, in this, what will happen? Yeah, physiological hernia will be reducted normally. At 10th week, it will go to its normal position. But due to the imperfectly closed umbilicus, okay, or due to the abnormality or weakness of the anterior abdominal muscles, again this hernia, again the loop of intestine, like this it will come. Okay, but here you will find there is no amniotic membrane, but here there is the subcutaneous tissue and skin. Now, what will happen if there is no rotation? Okay, can you see here the stomach, the simply the duodenum is coming, like this will be the small intestine in one position, large intestine in one position. Okay, so do you remember in the today's case, did you see something about malrotation? Yes?
Yes, we saw.
Yes. Okay, so maybe there is this, so this is the non-rotation. Okay, so in this, the midgut undergo counterclockwise only 90 degrees. We have three rotation of 90 degrees, but here there is only 90-degree rotation. So what has happened here? The caudal limb of midgut is returned to the left side and cranial to the right side. So whole of the large intestine on the left side, whole of the small intestine to the right side. There could be reverse rotation. Okay, so in this the midgut has rotated clockwise. So in this you can see in normally we know duodenum is behind the transverse column, but here you will find that duodenum is anterior to the transverse column. Okay, and it lies anterior to superior mesenteric artery also. So same we have the abnormalities or anomalies in the recanalization. So if there is imperfect recanalization, there could be partial occlusion, stenosis, complete occlusion, atresia, okay, or sometimes there is imperfect in which half part will be having the obstruction, okay, and this atresia and all are common in the ileum. Mostly it happens in the ileum, and sometimes this lumen will have some like this, it will have some membrane called as the diaphragmatic atresia. Okay, and we know if there is imperfect recanalization like this, here you can see the recanalization is not complete. Okay, it is imperfect, so it may lead to formation of the two tubes parallel. Okay, like this. So this will be the intestinal duplication. This also will happen commonly in the ileum. So now we know the hernia, the physiological hernia and its reduction. So, and we know there it is connected with the vitelline duct. Okay, it should disappear completely. You remember it should disappear completely. Okay, and which will become finally the Meckel's divertic. What is Meckel's diverticulum? It is the embryological remnant. Okay, it is the embryological remnant. But if there is something which is not fused, it may lead to fistula. Okay, it may lead to fistula, it may lead to the presence of the cyst, it may lead to the sinus. Okay, so here you can see this is the sinus. Okay, it means there will be like umbilicus is completely closed, so in that condition there will be something, some watery or some serous fluid will be coming out from the umbilicus. Okay, from this there could be a cyst. There could be a complete passage. Can you see there is a complete passage between the intestine and the umbilicus or vitelline duct here. Now, what is the volvulus? This is also one of the condition you can come across. Okay, so there is abnormal rotation of small intestine. Okay, so because after rotation, everything should get fixed to its normal position. But if the mesentery will not be fixed to its normal position, what will happen like this? Can you see this is the mesentery which is getting twisted? The superior mesenteric vessel here you will find that it will be obstructed due to the twisting of the intestinal segment. Okay, this is also one of the condition which is the emergency. If something like this is happening, the patient should go emergency under operation or under surgery. So what could be the anomalies of the cecum and appendix? So sometimes if the cecum is not fixed, it is called as mobile cecum. Okay, this is the incomplete fixation of the ascending colon. Okay, and then the cecum, if it is not fixed, it may herniate into right inguinal canal. The cecum may be present over the left side. Okay, generally it will happen along with all the organs. So always remember, this rotation is very rarely only with the one organ. Generally there will be, it is associated with other organs also. Okay, as we know, first when it develops, the cecum will lie below the liver, subhepatic. Okay, and suppose if it is not descent, it is present over the inferior surface of the liver, so it is called as subhepatic cecum and appendix. Okay, it's present, sometimes it will not cause any problem, but if there is inflammation of the appendix, patient will come to you, but when you will check the right iliac fossa, you will find there is no appendix, no cecum. So sometimes it may be in the subhepatic area. Yes, so we have the hind, just I will finish in just 5 to 6 months, because in hindgut we have two things. Okay, what are the structures? One third of the left, one third of the transverse colon, descending sigmoid rectum, and upper part of the anal canal. Okay, and you will find there is additional urinary bladder and urethra which also develops from hindgut. So just I will give you one review. I will not tell everything to you. So when you see the, yeah, so this is our hindgut, right? So in the hindgut, the caudal part, this is the caudal part, which will expand to form the cloaca. Okay, so let's divide the hindgut into this upper part or cranial part and caudal part. Okay, the caudal part, it is called as the cloaca. Okay, in the cloaca we have the cloacal membrane. Here we already know that there is a cloacal membrane which is the lowermost part of the gut tube. Okay, and we also know that there will be opening of the mesonephric duct. Okay, on the side of the cloaca where there will be opening of the mesonephric duct. Okay, so why it is there? So we know because it is going to develop the urinary bladder and the urinary part of urinary system. Cranially, it is continuous with the hindgut, and ventrally it will receive the allantois. Can you see? This is allantois. What will happen finally? This cloaca will divide into two parts. Urorectal. Okay, this part which is by the urorectal septum. Where is the septum? This. Okay, so this is the septum which will grow like this and which will divide into two different parts. Okay, what are these two different parts? They are primitive urogenital sinus and a dorsal part, anorectal part. Okay, so this is the urorectal septum which has divided it into two parts. This is called as the urogenital sinus and this is called as anorectal part. Okay, so we will know that the dorsal part of or the anorectal part will form the rectum and upper part of anal canal. Okay, so details of the cloaca, inshallah, we will see in the development of urogenital system. Okay, because just remember here that the distal part of the hindgut will divide into or will form the cloaca, Okay, the cloaca will be divided into two parts by the urorectal septum, this one, in which the part which is anterior, okay, this is which is the urogenital sinus, the posterior it is the anorectal canal. And as we saw in the beginning, cloacal membrane, so the cloacal membrane also anteriorly it will become urogenital membrane, posteriorly it will become anal membrane. So this anorectal part will form rectum and upper part of anal canal. So this I will skip for now. This we will see in the our urogenital system. Okay. So then we have the cranial part of anal canal. So it is endodermal in origin. It will develop from the cloaca, from the dorsal part of cloaca or anorectal canal. Then what about the lower part of the anal canal or caudal part? So it is ectodermal in origin. Always remember the lower part, it is ectodermal in origin. It will derive from the proctidium. Okay, an anal membrane is surrounded by the mesodermal swelling, which is called as anal tubercles here. Okay, and it will form a depression for the anal pit. This is the site for the anal membrane, which will rupture at the end of 8th week. Okay, so do you remember? I believe you have studied the detail of anal canal in life cycle. So here we have the pectinate line. Okay, where here? The pectinate line, it is between the ectodermal and endodermal origin of the anal canal. Or you can say above the pectinate line, this area it is endodermal in origin. Below the pectinate line, this area it is ectodermal in origin. So just always remember the pectinate line, okay, and which will represent the site for the anal membrane. So what could be the problem or abnormalities in the hindgut? Congenital megacolon. Okay, can you see? It is mega means so enlarged, dilated. So at the during the 5th to 7th week, okay, in the wall of the colon, you will get that the neural class cells will migrate. Okay, so they will form the autonomic ganglion. But if these cells will not be migrated and will not come to this wall, what will happen? So there will be absence of autonomic ganglion cells in myenteric plexus. Okay, so what will happen? This absence will lead to dilatation of the segment of the colon. Okay, not whole colon, only the small segment may be dilated. Okay, and it will happen only in, it will involve only rectum or and sigmoid colon. Okay, then this is one of the common cause for the neonatal obstruction of the colon. You may get patient with like distended abdomen, okay, like this, okay, not able to pass the motion. So it could be the cause that it is called as congenital megacolon, and another name is Hirschsprung's disease. Okay, Hirschsprung's disease. Imperforated anus could be one of the cause. Okay, so it will be the presence of mesoderm between the two layers of anal membrane. So here also the patient or baby will come to you that is he has not passed the motion, not feces. Okay, anal agenesis, it could be with or without fistula. So in this, the anal canal may end blindly, or there will be any other ectopic opening, means at any other site. Same anal stenosis, okay, or atresia. Okay, there could be the membranous atresia in which the anal membrane has not been ruptured at 8 weeks. Okay, so there will be thin layer of the tissue will be present. Okay, so these are the different structure where you will find the anorectal fistula, Okay, and here you will find that there is no opening here. Okay, and there you will find that anal membrane has not ruptured. Okay, so there is no opening and there is no connection with the exterior. Okay, so this will be same we have seen. Maybe there is agenesis which can be with fistula. Okay, means agenesis means completely agenesis. Okay, but sometimes there will be fistula with another organ. Okay, like connection with the bladder, rectovesical fistula, or there could be a connection with the urethra, rectourethral fistula, or with the vagina, rectovaginal fistula. Okay, so if there is a passage of meconium in the urine, you can suspect that there is a fistula. There could be rectal atresia due to abnormal recanalization of the colon. Okay, so we finish here because the lecture was very lengthy, so I tried to finish. Okay, so there are some more important information about the cloaca which we will cover inshallah in the our next embryology lecture about the urogenital or urinary system. Any questions with this?